Hi, good morning everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So guys, let's crack NEET PG together. A little about me. I am Dr. Sasha Remedies. I've done my MBBS from Father Muller Medical College, Mangalore, MD in Anesthesia from Father Muller Medical College, Mangalore. I have two publications and one paper presentation in the field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. So guys, let's crack NEET PG together. And on Unacademy, which is one of India's largest learning platform, today's topic will be Myasthenia Gravis. It is an autoimmune disorder, and we will be discussing that. A little about Unacademy now. What will you get out of Unacademy? Well, we have our daily live classes where you can chat with your educator, engage in discussions, clear your doubts and answer polls, and all this is while the class is going on. So what happens in a coaching institute? So when you go for a coaching class, first of all, you waste time traveling, you waste your energy. It is quite taxing on you, right? You have to get to class on time, and you have to take into account your traffic and whatever various other issues. And even once you get there, depends on what seat you get and whether you can get the educator's attention. And these are big classes, so you don't know if the educator might not be able to clear everyone's doubts. It might be difficult for him too. So with all that, it becomes kind of difficult for everyone's doubts to be cleared then and there at that point. And but over here, you can chat with your educator and clear your doubts while the class is going on. So we interact with you during the class, either during the class or at the end of the class, but we have constant interaction with you all, and we are here to clear your doubts and to help you all. Now, these are all structured courses, and they are in line with your exam syllabus to help you best prepare for it. So these are all structured courses, and all according to your exam syllabus we have researched, and whatever we feel is best for you all, we help you all prepare. Now these are all live tests and quizzes, and we conduct live tests and quizzes which obviously will help you all evaluate your preparation and on a regular basis, and can you all get a detailed analysis on your performance. So we prepare our quizzes in line with the NEET PG, what the important parts are, and we help you all best prepare for it. And of course you all have unlimited access. A one-time subscription can get you all access to all our live and record courses, and you can watch from the comfort of your home, the comfort of your device. So wherever you are, whatever you are doing, right? So from the comfort of your home, wherever you are sitting, the comfort of your device. So whether you are traveling, whether you are at home, whether you are on the way somewhere in a car or whatever, you can sit whatever device, whether it's your phone, whether it's your laptop, whether it's your iPad, your tablet, you can watch via the app. These are some of our top educators on the platform: Dr. Nikita Nanwani, Dr. Preeti Sharma, Dr. Mohammad Azam, Dr. Devish Mishra. Dr. Nikita Nanwani is a PG mentor for radiology as well as mnemonic and concepts on all must-know topics encompassing all subjects. Now, these are the courses offered. There are a variety of subjects, 19 subjects. These are all your MBBS subjects. Of course, I understand these are not easy subjects. There's a lot to cover under these subjects, and even during MBBS, it has been. These subjects are very vast subjects. These are not small subjects which can be covered immediately or anything like that. So these subjects take time, and the marks allocation is different for each. So anesthesia has about 11 marks, and well, it's a very scoring subject. So if you cover your ground well, it is a very scoring subject. You will you need not miss out on the marks when it comes to anesthesia. So these smaller subjects, when you score, right, when you do not basically when you do not when you have covered these small subjects well, it's more scoring, because you are accumulating 11 from radio, 11 from anesthesia, 11 from the radio psychiatry. So you're getting all those points. So these are scoring subjects because they ask a particular set of questions, and we help you best prepare. So of course, anesthesia covers some medical topics too. Like today, myasthenia gravis. I'm actually going to be covering the anesthetic management. But whatever said and done, you'll still, like uh, it's like a revision for y'all. And that I'm telling you, getting 11 marks is easy in anesthesia. So some of the ongoing courses in our platform, we have neurophysiology, GI surgery, cardiovascular thoracic surgery, course on larynx, respiratory system, pathology. Now coming to the subscription. Now guys, as you all can see on the screen, there are 5 types of subscriptions, right? Now quite frankly, you have 19 subjects to cover. These are not small subjects. Each subject is so vast, so much in depth. Now if you choose your 1, 3 and 6 month subscription, it's not impossible, but it's a little difficult to clear, to uh, it's a little difficult, as per se, to say that you can cover these subjects in 6 months, because it's not very practical. I'm not saying it's impossible, but it's a little difficult to cover 19 subjects in depth in 6 months. They can ask you anything from anywhere. It's the NEET exam, right? I would highly recommend you all go for the 12 and the 24-month subscriptions. So it gives you all time to prepare. It's knowledge that you all are gaining at the end of the day. There's nothing wrong with that. It's only good for you all. So it is more structured, more in line, and I feel it will be much more beneficial to you all. I would have gone for that, and I did go for that. I did take a year off and study, and I am where I am today. I enjoy what I do. And of course, 12 months, you can use my code at the bottom of the screen, as you all can see. In At the bottom of the screen, as you all can see, my code SASHA. Please use my code and you all can avail a 10% discount. So guys, hurry, subscribe, don't delay. It's a This exam is a vast exam. You'll need to be, of course, well prepared, and you'll need to start preparing fast. So hurry guys. Now again, the 24-month subscription, um, the 24-month subscription, uh, it's more economical too. These two, I'm sorry, I forgot to bring in that point. These two options, 12 and 24 months, are much more economical. Now why would I say economical is because it's a one-time subscription. Okay, so after 6 months you will have to subscribe again. You cannot access the live classes, recorded classes, the tests, the quizzes, the mock exams. You cannot access them. So it is just 24 months. It's you. So you will have to pay again after 6 months. But 24 months, you've paid that one time. In those 2 years, in that 1 year, 12 months, whatever, you can access it whenever you want. So again, use my code at the bottom of the screen, SASHA, and avail your 10% discount, guys. Hurry, do subscribe, and let us help you prepare for your NEET PG. So coming to today's topic, which is myasthenia gravis, and today's topic, which is myasthenia gravis, and I'll be dealing with the anesthetic management of myasthenia gravis. So it is a neuromuscular disorder which causes weakness and fatigability of the skeletal muscle. Now the hallmark of this weakness and fatigability. The hallmark of this weakness and fatigability is that it worsens after exertion and improves with rest. So it worsens after exertion and it improves with rest. So the patient gets up in the morning, the patient wakes up from sleep energized and feeling good, but as the day progresses, their weakness worsens. So it is an autoimmune disease that is caused by antibodies. It is an autoimmune disease which is caused by antibody to cell and blockade of the nicotinic acetylcholine receptors. So the thymus is said to play a role in 85% of the patients. This thymus produces T cell lymphocytes antibodies to these T cell lymphocytes. So basically, the thymus epithelial cells and the acetylcholine receptors have a similar epitope, a similar antigen. So because of that, embryologically, it is said that they have a similar epitope, and because of that, it is said that the thymus produces these antibodies to these T cells. Okay, it causes a cross reactivity, producing an antibody to it recognizes the nicotinic acetylcholine receptors as neoantigens, and it stimulates the T cell as antibodies to block the nicotinic acetylcholine receptors. T cell stimulation occurs after sensitization within the thymus to a protein similar to embryonic acetylcholine receptor. So because the thymus recognizes this protein, because thymus and the acetylcholine receptor share a similar epitope, a similar protein. So the thymus recognizes this protein and causes T cell stimulation against this protein, which leads to the production of anti-acetylcholine receptor antibodies and the destruction of the acetylcholine receptor. So the clinical features is it is basically insidious in onset, right? So it is insidious in onset, occurring over months to years. So it can take over months to years to develop. So it need not. The initial symptoms are ocular, that is ptosis and diplopia. So your ptosis can be unilateral or bilateral. It can be symmetric or asymmetric. And this ptosis typically alternates between eyes. Okay, so the ptosis can be unilateral, bilateral, it can be symmetric or asymmetric, and it typically alternates between eyes. Then the diplopia uh, is usually intermittent. The diplopia is usually intermittent. So the extraocular involvement can vary from single muscle to total ophthalmoplegia. So either it can be just one muscle involvement or it can be total ophthalmoplegia. Pupil is usually spared. The ocular symptoms can progress to generalized ones in 80 to 85% of my patients with myasthenia gravis. So in 80 to 85% of the patients, ocular symptoms will progress to generalized symptoms, and prognosis is better when it is confined to the ocular symptoms, especially for more than 2 years. So the prognosis is better if it is just confined to ocular symptoms for more than 2 years. So involvement of the bulbar muscles, it can, so the bulbar muscle involvement can lead to your dysarthria, that is difficulty in speaking, dysphagia, that is, I'm sorry, difficulty in swallowing, dysarthria, dysphagia, then difficulty in chewing, so difficulty in chewing. So these are your bulbar involvement, that is your dysarthria, dysphagia and difficulty in chewing. So basically this is, and finally it progresses to respiratory depression. Also there can be a nasal twang in the voice. Okay, so a nasal twang in the voice Nasal twang in the voice indicates palatal muscle weakness. So it indicates palatal muscle weakness. So nasal twang can indicate your palatal muscle weakness. Then of course you have the myasthenia snarl. That is weakness of the muscles of the elevators of the basically the elevators of the lip. Myasthenia snarl. This myasthenia snarl is elevators of the angle of the mouth, that is your levator labii superioris and your levator anguli oris. So your levator labii superioris. These are the elevators of your angle of the mouth. And your I'm sorry. Okay. Okay, so basically your levator labia superioris and your levator anguli oris. So it affects all age groups. Your limb muscle weakness occurs in only 15 to 20% of the patients. Okay, limb weakness occurs in only 15 to 20%. The proximal muscles are more involved than the distal muscles. So proximal muscles more than distal muscles. The proximal are involved more than distal. It affects all age groups. The peak incidence is 20 to 30 years in women and 50 to 60 years in men. Characteristic is weakness and fatigability on repetition. There is weakness of ocular muscles, facial muscles, and proximal muscles. There is, of course, there can be periods of relapses and remission, and finally, it can lead to respiratory muscle weakness. Many factors can exacerbate the factors which increase myasthenia gravis. So sometimes there can be neck muscle involvement too. So there can be neck muscle involvement too. The muscles of the patient won't be able to keep his neck upright. The neck will be continuous bowed down like this. So the rector capitis posterior major and the rector capitis posterior minor are the two neck muscles which can be involved. Then many factors, the factors that exacerbate the symptoms. So factors increasing the clinical features, basically bright sunlight, any sort of stress actually in such stress, physical or emotional stress, bright sunlight. Uh, this sunlight issue is particularly in the case of ocular symptoms. Any increase in temperature that is seen with hyperthyroidism or with fever, basically infections. Then your medication. So basically your medications. 1 minute. Medications like quinidine, antibiotics, so your antiprocainamide, aminoglycosides, calcium channel blockers, penicillins, all worsen the symptoms. So if the patient is on these symptoms, on these medications like your aminoglycosides, penicillin, calcium channel blockers, procainamide, quinidine, there are chances of worsening of myasthenia gravis. So the incidence is 1 in 30,000. It is more common in women. Patients less than 16 years account for only 10% of the cases, and patients have a higher incidence of other autoimmune diseases. So these patients have a higher incidence of other autoimmune diseases like diabetes and SLE, and so it's dangerous. So we have to rule out all these other autoimmune diseases in these patients. Now, this 1 minute. Okay, it's like that only. So this it is in children. It can be classified as transient neonatal, and juvenile. Now, your transient neonatal is basically occurs in 21% of the infants born to mothers with myasthenia myasthenia gravis. So basically, what happens is the antibodies passively transfer from mother to fetus. So the antibodies passively transfer from mother to fetus, and these they can present with feeble cry, poor feeding, and of course respiratory distress. It lasts around 18 days. It will last. The other form is the neonatal persistent, which at onset is at around 2 to 3 months. No antibodies are seen, and it is very rare. The juvenile is very similar to adult myasthenia gravis. So, like I said, they can have various other autoimmune diseases. So, when you are taking a history of these patients, like when you prior to surgery, when a history is being taken, uh, autoimmune diseases like autoimmune thyroid, basically the TSH, the entire TSH, FT4, T3, anti-TPO, these are thyroid peroxidase. All these will have to be checked when we are doing a pre-op evaluation. Then we have to rule out rheumatoid arthritis. So any history of rheumatoid arthritis will have to be sought from these patients, and what medications they are on. Then of course we have our SLE, diabetes. So all this history has to be elicited from the patient as to whether they have these comorbidities. Then we have a diabetes mellitus. Now coming to the diagnosis. So from the diagnosis point of view, history and clinical examination. So history and clinical examination. In history and clinical examination, prolonged upward gaze, holding an outstretched hand in abduction, and vital capacity. So these are some of the clinical tests that can be used to basically come to a diagnosis of myasthenia. But of course, this is not enough by itself. It has to be encompassed by the diagnostic test too. So in myasthenia patients, like I said, the thymus plays a role. So 10% of the times the thymus gland has a tumor, and 85% of the time this is produced because of hyperplasia of the thymus gland. So the diagnosis is usually made of clinical examination and history and confirmed by the diagnostic test. So clinical examination wise, monitoring prolonged upward gaze, the patient won't be able to hold the gaze upwards for a long period of time. Holding an outstretched hand in abduction, again the patient will get fatigue, and performing vital capacity breaths. So the electrophysiological test, so basically one is diagnosis based on history and clinical examination, electrophysiological test, serological test, and pharmacological tests. So your electrophysiological test, 50 to 5 50 to 70% sensitive, not 7 not 5, I'm sorry. So it is 50 to 70% sensitive, but it is not specific for myasthenia gravis. There's a decrease in twitch and post-tetanic facilitation, that is on neuromuscular monitor. There's a decrease in twitch and post-tetanic facilitation. Now electromyography is more accurate. Okay, it is more accurate to use electromyography. So electromyography is basically it evaluates the time interval between two action potentials produced by two muscle fibers. Produced by two muscle fibers in the same motor unit. Basically, in a motor unit, the muscle fibers are innervated by a single nerve. So the time interval between the two action potentials, uh, uh, when two muscle fibers are stimulated by one nerve, this is known as jitter, and this jitter is increased in patients with myasthenia gravis. Okay, so that is how your physiology electromyography works. Serological test. Now, and acetylcholine receptor antibodies are seen in 80% of the patients with generalized myasthenia gravis and 50% with only ocular symptoms. There can be antibodies to striated muscles are also detected, and their presence usually signifies some involvement of the thymoma. The antibody level does not correlate with severity of the disease per se, but it is still more specific. So it is one of the most antibiotic serology is more specific for myasthenia gravis more than any other test, even though it does not correlate with the disease severity. Now the pharmacological test is edrophonium, 2.5 to 2.9 mg is given. So basically, first the patient is fatigued with the task, and suppose if patient is made to talk a lot, then the patient will have slurred speech, and post that this edrophonium 2.5 to 2.9 mg can be given, and there is improvement within 2 minutes. So this is your forward arm abduction test, where the patient is asked to put his arms out, arms out. He is asked to hold his arms out and abduct his hand, and the time interval for how long the patient can hold his hands um like this is depicted, and according to that, he will we can assess. So diagnosis and evaluation, like I said, AntiCholinesterase test, the edrophonium test, 2.5 to the patient is made to perform some activity till he is fatigued. Following that, 2.5 to 9 mg can be given, and you have to look for improvement in muscle strength. Now coming to differential diagnosis, so a number of disorders can mimic myasthenia gravis, and these should be included in the initial differential diagnosis. So a number of disorders can mimic myasthenia gravis, right? And so in the initial one is your Lambert-Eaton syndrome, as both cause of thalmoplegia and muscle weakness. Botulism Botulism, however, affects cranial nerves early. It also causes ophthalmoplegia and muscle weakness, same as above. But it affects the cranial nerves. Botulism affects the cranial nerves much earlier. Then, of course, we have our thyrotoxicosis. Then various drugs like aminoglycosides, quinine, procainamide, calcium channel blockers, dipencilinamide, all can cause myasthenia-like symptoms. And we have our brain tumors and you know amyotrophic lateral sclerosis, amyotrophic lateral sclerosis, brain tumors, all have to be ruled out. These are the differential diagnoses as they can present to some extent with features suggestive of myasthenia gravis. So with coming to Lambert-Eaton syndrome, so there can be a depressed level of reflex, dysautonomia, and weakness improves with activity. So with myasthenia, weakness does not improve with activity, but over here weakness is improves with activity in case of uh, Lambert-Eaton. So the associated uh, conditions, like I said, the differential diagnosis, it can be thymic abnormalities, hyperthyroidism, rheumatoid arthritis, because these are all autonomic disorders themselves. So coming to the differentiation between Lambert-Eaton syndrome and myasthenia gravis. So the area of weakness for my Lambert-Eaton is proximal limbs like legs more than arms, and the myasthenia gravis is basically your extraocular muscles, bulbar muscles, facial muscles, and of course the proximal. When it comes to limbs, proximal more than distal. But the first, basically, the ocular symptoms are the most common. Then your response to exercise, it improves with strength. So with exercise, it improves. Whereas over here, with exercise in myasthenia gravis patients, they get fatigued. Muscle pains are common with Lambert-Eaton syndrome and they are uncommon with myasthenia gravis. Now, reflexes are normal in myasthenia. They are absent or decreased in Lambert-Eaton. Lambert-Eaton syndrome, they are absent or decreased. Lambert-Eaton is seen more in males, myasthenia is seen more in females. The coexisting pathology can be small cell carcinoma of the lung, whereas with myasthenia gravis it is thymoma. Response to drugs, it is sensitive to succinylcholine. It is not resistant. The response is variable. So we will discuss this in the coming slides as to why the response to succinylcholine is variable. So to non-depolarizing muscle relaxants, it is highly sensitive in both cases. And anticholinesterase drugs, Lambert-Eaton syndrome patients have a poor response, whereas these myasthenia gravis patients are treated with these anticholinesterase drugs. Now coming to the treatment, so anticholinesterase medication. So by inhibiting the metabolism of acetylcholine, so these basic as anticholinesterases, they inhibit acetylcholine esterase. This acetylcholine esterase is the main enzyme which degrades acetylcholine at neuromuscular junction. So it degrades acetylcholine. So when this is inhibited, it inhibits metabolism of acetylcholine, these anticholinesterases, and as a result, the drug prolongs the duration of action of acetylcholine at the neuromuscular junction. The patient's response is variable. Okay, So it can vary from patient to patient. Within a patient also it can vary over the course of the day. As a result, patient education and understanding of for the patient about the disease and the drug is very important, so that the patient can adjust the dose according to the symptoms. So the most common side effects of this anticholinesterase are due to the muscarinic side effects. That is basically your increase in secretions. So the increase in secretions can be problematic, particularly in those with bulbar palsy. So those patients with bulbar palsy can, if because of this increase in secretions brought about by anticholinesterases, they already have compromised swallowing, right? Their swallowing is already compromised, so they can aspirate, which can lead to aspiration and death. It can lead to aspiration, then aspiration pneumonia, and the whole series of events. So excessive treatment of this anticholinesterases can result in something known as cholinergic crisis. Okay, this cholinergic crisis will manifest as profound weakness. So there will be excessive weakness. So this cholinergic crisis can result in profound weakness. It is due to uh, excess acetylcholine at the neuromuscular junction, which due to, I'm sorry, just a sec. Yeah. So this cholinergic crisis is causes profound weakness. It is due to increased acetylcholine at the neuromuscular junction. As a result, there will be persistent depolarization. There will be persistent depolarization. So uh, this will be sensed as weakness, right? This persistent depolarization will be sensed as weakness, and this vicious cycle continues because you'll think that the weakness is because of myasthenia. You will go on giving anticholinesterase. The acetylcholine will go on increasing at the neuromuscular junction. Persistent depolarization will continue occurring, and instead of treating, you will be exacerbating the cholinergic crisis. So to differentiate between the two, the pupil size will help. Okay, so in myasthenia gravis, because of hypercarbia, so this pupil size helps to differentiate between myasthenia gravis and cholinergic crisis. So in myasthenia gravis, the hypercarbia that is seen causes sympathetic stimulation, causes stimulation of the sympathetic nervous system, sympathetic system, which leads to dilation of the pupils. However, this cholinergic crisis due to excessive acetylcholine, so this cholinergic crisis because of excessive acetylcholine, it will cause constriction of pupil. So this is how you can differentiate between cholinergic crisis and myasthenia gravis. So the drug of choice is pyridostigmine because it has lesser muscarinic, I'm sorry, lesser muscarinic side effects than neostigmine. Okay, and the dose is 30 to 120 mg that can be divided into 3 to 6 doses in 24 hours. And the onset of action is about 15 to 30 minutes. The peak occurs in 1 to 2 hours, and the duration of action of pyridostigmine is 3 to 4 hours. Now, coming to thymectomy, so basically, a thymoma. This is the surgical approach. So all generalized. It is advised in all generalized patients with generalized myasthenia gravis symptoms. It is not done in prepubertal and those with ocular symptoms. So those patients in prepubertal patients and those with ocular symptoms, thymectomy is not advised. So thymectomy is basically to induce remission. So the other modes of treatment along with anticholinesterase drugs are your immunosuppressants and steroids. So basically thymectomy is not, it's not like the disease will resolve completely. It is to induce remission. Okay? This permits a decrease in immunosuppression medication. As a result, the side effects of these immunosuppressant drugs will be decreased. So the thymectomy is basically to induce remission so that the dose of immunosuppressants can be decreased, and it is advised in patients with myasthenia gravis who present with generalized symptoms. It is not advised in prepubertal and patients with ocular symptoms. Thymectomy is not advised. So why thymectomy is because these thymic epithelial cells and acetylcholine receptors share similar epitopes. As a result, those antibodies are produced, those T cell lymphocytes are produced, and the approach can be transsternal or transcervical, right? So the approach to surgery can be transsternal or transcervical. So a thymoma is basically seen in 15% of the patients, and hyperplasia is seen in only 80% of the patients. Now 50 to 80% of the patients undergoing thymectomy will show an improvement in will show clinical improvement. So 50 to 80% will actually show clinical improvement after thymectomy, whereas 21 to 38% will show remission after thymectomy. Okay, so this is it has seen quite beneficial. So transsternal and transcervical approach are more are used. The transcervical approach is less minimally invasive and is better. As a result, the mortality with this is 0% as compared with the 9% seen with the transsternal approach, and the incidence of post-op ventilatory support again with the transcervical approach is 10%, as is only 10% as opposed to 90% seen with the trans. I'm sorry, this is not working for me, but as opposed to the 90% seen with the transsternal approach. So the transcervical is better because it is less minimally invasive, and the mortality and incidence of post-operative ventilatory support are minimum. Now coming to immunosuppression. So basically steroids are used for this. So prednisolone 10 to 15 mg per day, increase every 2 to 3 days by 5 mg per day till there is improvement. The immunosuppressants, the other immunosuppressant drugs, are azathioprine and cyclosporin. So basically this immunosuppression is used to complement anticholinesterase treatment. Okay, it is not used to replace it. It is just used to complement anticholinesterase treatment to reduce amount of anticholinesterase acetylcholine receptor antibodies and diminish the acetylcholine receptor reactivity to the peripheral lymphocytes. So basically the steroid role is it decreases inflammation and infection, right? So it reduces the amount of antibodies and it decreases the receptor reactivity to these T cell lymphocytes. However, the side effects are immunosuppression, cataracts, infection, myopathy, osteoporosis, diabetes, peptic ulcer. So these are all the steroidal side effects which can occur. Cytotoxic drugs like cyclosporin and azathioprine. However, the peak effect azathioprine are used. However, the peak effect for azathioprine uh, it takes about 1 to 2 months. I'm sorry, the peak effect of cyclosporin takes about 1 to 2 months, but its side effects are nephrotoxicity and hepatotoxicity. However, the peak effect of azathioprine can take up to a year. So these are just basically used to complement. These immunosuppressants also are used to complement the steroid so that the dose of steroid can be decreased as such. Plasmapheresis also can be provided. So it's basically multimodal treatment to treat patients with myasthenia gravis. So the plasmapheresis also can be provided and has led to rapid improvement. Now, what is the role, what is the effect of pregnancy on myasthenia gravis? So the effect of pregnancy on myasthenia gravis is basically unpredictable. Okay, and exacerbation likely to occur in first trimester and immediate postpartum. So the effect of pregnancy and myasthenia is unpredictable. So it can occur in the first trimester and immediate postpartum. Symptoms improve in the second and the third trimester in approximately 40% of the women. And the mortality is related to the duration of the disease. So disease with 1 year and all, more chance of survival than patients who have had disease for more than 7 years. Now, what is the effect of myasthenia gravis on pregnancy? There is no effect as such. The children are usually born pretty healthy and normal. However, those three neonatal things in children that I have explained may occur. Now, coming to the anesthetic management. So, the pre-operative evaluation. Basically, the pre-operative evaluation. So, you have to firstly you have to evaluate the duration and severity of the disease and the dose of pyridostigmine that the patient is taking. Okay, because this information can guide the anesthesiologist in formation of the particular anesthetic plan, because they have to the anesthesiologist will have to choose the pre-op medication and the type of anesthesia uh, correctly depending on the dose or how long the disease has been there, the dose of pyridostigmine, because there can be a lot of drug reactions taken place. So patients with mild symptoms of anticholinesterase can be discontinued this because there can be a lot of drug interactions, right, because of this anticholinesterase, and it makes the patients more susceptible to these vagal arrhythmias when they are on these anticholinesterases. So if they are on mild doses of anticholinesterases, it can be stopped. However, patients who are dependent on the medication, it has to be continued. So the clinician has to take the clinician has to go both ways, in the sense he has to assess the risk benefit ratio and then decide whether the anticholinesterase treatment has to be stopped or has to be continued. Okay, then the metabolism of succinylcholine, mivacurium and other local anesthetics may be slowed because you are there is these are anticholinesterases and it can affect these drugs 2. Uh, so assessment of other autoimmune diseases. So these patients are usually predisposed to other autoimmune diseases. So patients have to be evaluated for, like I discussed below, hypothyroidism, SLE, pernicious anemia, pernicious anemia, and Um, so they have to be evaluated for these other diseases. Now, coming to investigations wise, you have to ask for a complete blood count, uh, the liver function test, the renal function test like your blood urea, creat, liver enzymes have to be evaluated, and of course you have to rule out hypokalemia because serum electrolytes should be done, as hypokalemia worsens muscle weakness. Then the cytotoxic, like if you're using cyclosporin and all, the toxicity levels have to be determined, and um, then the airway has to be assessed if the patient will be undergoing general anesthesia. Glycopyrrolate can be given to these patients pre-operatively to reduce secretions, and of course the stress dose of the corticosteroids has to be covered because these patients most of the time will be on corticosteroid doses. So the stress dose has to be covered so that the patient does not go um, ad- uh, into crisis, steroid crisis. And of course, the thymoma evaluation has to be done. So thymoma is regarded as an anterior mediastinal mass, so it has to be kept in mind that this can cause tracheal compression and deviation. So your CT scan, MRI, chest X-ray, and all has to be done, and accordingly, the plan of anesthesia will be decided. Now, your intraoperative management. So your so should the patient be pre-medicated or not? The patient can be pre-medicated. Like I said, you can give glycopyrrolate, but opioids and all that have to be used cautiously. So intraoperatively, a nerve stimulator. I'm sorry. A nerve stimulator has to be used to assess muscle strength. So whether a muscle relaxant is used or not, a nerve stimulator has to be used to assess the muscle strength. So whether, because these it helps in assessing the whether there a crisis is occurring or not. So muscle strength should be assessed even if muscle relaxant is not used. Then the opioids should be used cautiously as these patients are very sensitive to the ventilatory depressant effects of these opioids. They are extremely sensitive to neuromuscular depressant effects of inhaled anesthetics. So these inhaled anesthetics exaggerate the neuromuscular depression and cause more weakness. The patient should be extubated awake, responsive, and patient should be able to generate a negative inspiratory force of a minimum of minus 30 centimeter of water before extubation, and prior to intubation also pre-oxygenation is very important because these patients can desaturate very fast, and hence adequate pre-oxygenation prior to the procedure should be done. Now coming to whether neuromuscular blocking drugs can be used in these patients or not. So when we are talking about depolarizing muscle relaxants, so coming to these depolarizing muscle relaxants, right? So these muscle relaxants have a variable response, okay? So in patients, so the depolarizing muscle relaxants is basically a succinylcholine, okay? So in patients who are receiving anticholinesterase, there will be decreased number of functional receptors. So first of all, succinylcholine is rapid acting. It is a short acting depolarizing muscle relaxant, and the recovery is also rapid. Okay, but and it is a drug, because of this thing it is used for tracheal intubation. But the response to in myasthenia patients can be variable. Okay, and this variability basically depends on their medical treatment. So this variability depends on their medical treatment. So those not patients who are not receiving anticholinesterases, there will be decreased number of functional acetylcholine receptors, right? So there will be decreased number of functional acetylcholine receptors. So the decreased number of receptors will be resistant to the effects of succinylcholine, and those needs to be increased. Okay, so these patients are not taking anticholinesterase, but however, because of antibodies which are formed against these receptors, the number of receptors required to for the action of succinylcholine will be decreased, and therefore the dose will have to be increased to facilitate tracheal intubation. However, in patients who are receiving anticholinesterases, plasma cholinesterase activity is decreased. So because we're giving anticholinesterases, anticholinesterases also inhibit the plasma cholinesterases, which actually it inhibits these plasma cholinesterases along with acetylcholinesterases. This plasma cholinesterase or butyryl cholinesterase degrades succinylcholine, so the activity is decreased, and hence more amount of drug will reach the end plate, and the block can be prolonged. So that from 4 minutes, that is a normal time for succinylcholine block, it can be prolonged right up to 87 minutes when these patients are on acetylcholinesterase, because they degrade the enzyme plasma cholinesterase, which is used to degrade succinylcholine. So there will be more drug reaching the end plate, and the blockade can be prolonged. So although the use is not contraindicated, the clinicians prefer not to use it because of prolonged neuromuscular blockade. Now coming to the non-depolarizing muscle relaxants. So the non-depolarizing muscle relaxants, these patients, myasthenia gravis patients, are extremely sensitive to these drugs. So patients who are taking the non-depolarizing muscle relaxants, when given to these patients, they are extremely sensitive to these drugs. So now why? So the number of acetylcholine receptors is reduced to 70% in these patients, because why? They are blocked by the antibody. So the number of functional receptors is reduced to 70%. The number of receptors available is just sufficient to produce end plate potentials that are above the threshold potential. So the number of receptors that get blocked by acetylcholine are just sufficient to produce a depolarization, a weak depolarization. As a result, because there are less numbers, so the depolarizing muscle relaxants have to bind to a particular number of receptors. These have to bind to a particular number of receptors to produce muscle block, muscle relaxation, right? So these number of receptors are reduced, so the dose of the relaxant needs to be reduced. Okay, because the number of receptors are reduced, the dose as such will be reduced, because they have to bind less number of receptors to bring about that muscle relaxation. So hence that is why it is more advisable that intermediate acting muscle relaxants be used, as they are more suitable for patients with myasthenia gravis because of the shorter duration of action. Okay, now postoperative management. So this is some predictive criteria for prolonged ventilatory support. It is not that it is used by everyone, but it has been it's not a hard and fast rule, or it is not a proven criteria. But if the duration of myasthenia for more than 6 years is allotted 12 points, history of COPD is allotted 10 points, pyridostigmine dose more than 750 mg per day 8 points, vital capacity less than 2.9 liters avoided 4 points. So if the total number of points is less than 10, you can extubate the patient, that is take out the endotracheal tube from the mouth of the patient. If the points are more than 12, the patient might require ventilatory support. So guys, whether or not to like extubate a patient depends purely on the clinician, and of course the anesthesiologist has to be careful between the cholinergic crisis and the myasthenic crisis. Okay, both present with decreased response to anticholinesterase, that is your cholinergic crisis, as well as your myasthenic crisis, which can occur at the time of extubation. And cholinergic crisis, like we discussed, is usually caused by an overdose of anticholinesterase, and stress of surgery can lead to myasthenic crisis, but both will present with the decreased response to anticholinesterase. I'm sorry, both will present with muscle weakness. However, myasthenic crisis will have a decreased response to anticholinesterase. Okay, so with both myasthenic crisis or cholinergic crisis, there will be muscle weakness and sweating occurring. Both can be differentiated based on the patient's response to intravenously administered 10 mg edrophonium, which is anticholinesterase. Patients with the myasthenic crisis, though they have decreased sensitivity, will show some improvement, whereas patients in cholinergic crisis show there will be either worsening or no improvement. So patient of cholinergic and myasthenic crisis can be differentiated based on edrophonium, which is given with, where there will be an improvement in muscle strength in uh, patients with myasthenic crisis. So basically, Myasthenia gravis is an autoimmune disease where antibodies are produced against acetylcholine receptors. It is said that the thymic epithelial cells share a similar protein with the acetylcholine receptors, and this thymic cells produce activate the T cell lymphocytes to produce antibodies against these acetylcholine receptors. Hence, a less number of receptors will be present at the neuromuscular junction, less number of active receptors. It is seen more commonly in women in the reproductive age group. Men, it is seen at a later age group, and juvenile is much less. It is very less in patients less than 16 years of age, and the treatment involves anticholinesterase agents, corticosteroids, immunosuppressants, and surgery. In most of the times, it is thymic hyperplasia which leads to this. However, a thymoma also can lead to can cause this, and surgery is an option when there are generalized symptoms. Most often, the symptoms are ocular in nature, which generally progress to generalized symptoms. And when it progresses to generalized, the proximal muscles are involved more than the distal muscles. Ocular symptoms which are lasting for more than 2 years, or if it is confined only to ocular symptoms, have a good prognosis. And when the brain bulba is involved, when bulbar symptoms are dysarthria, dysphagia, difficulty in chewing, and it needs to be taken care of. And glycopyrrolate should be used in these patients because these anticholinesterase drugs cause increased secretions, and patients with bulbar palsy can aspirate. Then coming to the muscle relaxant, succinylcholine is used, but its dose the dose might have to be increased in patients who are not taking anticholinesterase because less number of receptors are available. However, patients who are taking anticholinesterase, the dose might have to be reduced, and in neuromuscular non-depolarizing agents, the dose has to be reduced because less number of receptors are there. So less number of drug has to bind, less amount of drug has to bind to the receptors. Succinylcholine has a variable response to in patients with myasthenia gravis, but the non-depolarizing muscle relaxers have a more definitive response. So guys, that's it for today. That was my class. Please do use my code. Please do use my code SASHA and subscribe. You will get a 10% discount. So guys, please hurry. Thank you. Have a good day.